Hello and welcome. We are diving deep today into one of the most intense and rapidly evolving fields in critical care medicine, managing ST elevation myocardial infarction, or
Yeah,
STEMI.
that's right.
We're aiming to move beyond just the basic guidelines to really explore the sharp end of intervention, the specific procedural, technical, and strategic calls that happen minute by minute in the cardiac cath lab.
hmm The real nitty-gritty.
I'm joined by my expert colleague to unpack this essential guidance. This deep dive is based on the authoritative SCAI expert consensus statement on the management of patients with STEMI referred for primary PCI.
A really important document.
Yes. Chaired by Jacqueline E. Tamas-Holland, MD, FSCAI, and Yoder Sandoval, MD, FSCAI, and published in the Journal of the Society for Cardiovascular Angiography and Interventions in 2024.
A very recent and relevant source.
Welcome to the funnel effect. So the mission today is really to give you, the listener, a shortcut to this high-level critical care knowledge. STEMI, where a coronary artery gets completely blocked, it's still a leading cause of, well, serious illness and death.
Absolutely.
Mhm.
Morbidity and mortality are still significant issues.
And the core life-saving action is timely reperfusion. Getting that artery open fast, mainly through primary percutaneous coronary intervention, or PCI.
Exactly. And while big guidelines from groups like the ACC and AHA tell us when to treat a STEMI, the SCAI consensus zeroes in on the how.
Ah, the practical part.
Precisely. It's like a technical roadmap for the interventional cardiologist and the whole cath lab team. It covers everything from, getting arterial access to handling tricky anatomy, dealing with unexpected problems.
Things the general guidelines might not cover in detail.
Right. Or newer techniques, special circumstances they just can't keep up with sometimes. So, just for clarity for everyone listening, STEMI, that's the severe heart attack type we're focused on. PCI is the procedure itself, opening the blockage, usually with a balloon, then a stent.
Okay.
And the cardiac catheterization laboratory, or CCL,
Yeah.
that's the high-stakes environment, the room where this life-saving procedure actually happens. We're essentially going behind the curtain of critical care here.
Perfect framing. Let's jump into the first big theme. Time. The source material hammers this home prompt treatment means better outcomes. Time is everything, right? At every single step. That whole reperfusion timeline concept.
It's non-negotiable. The foundation of good STEMI care isn't just about having skilled operators, though that's vital. It's about systemic efficiency. How quickly can the whole system mobilize?
So what does that look like in practice?
Well, the consensus document details the nuts and bolts for CCL team readiness. It stresses streamlined communication. It really starts before the patient even hits the hospital pre-hospital activation.
By the paramedics? EMS?
Usually, yes. EMS or sometimes the emergency department if the patient walks in. But the key is a single, unified activation system, whether it's a pager blast, a dedicated phone line, maybe an electronic app notification.
One button hits everyone.
Exactly. The whole team, the interventionalists, the nurses, the techs, gets the alert simultaneously. No delays waiting for calls down the chain.
And the clock starts ticking immediately. What's the actual target for getting that team physically in the lab? Because, getting people mobilized at 3 a.m. is a different beast.
No, it's a huge logistical challenge.
Yeah.
And every minute counts. That's ischemic time. Heart muscle is actively dying. The consensus states the expectation for the CCL team members to arrive is 20 to 30 minutes after they get that notification.
Okay, 20 to 30 minutes.
But the ideal, the real benchmark for an efficient system is 20 minutes. Hitting that consistently requires really structured on-call schedules, clear rules about how far away staff can be, and frankly, strong institutional support to make it feasible.
That pressure, that 20-minute target, leads right into this idea of the ED bypass, doesn't it? For stable patients coming in by ambulance straight to a PCI hospital sounds super efficient.
It is. It's a proven time saver. The data shows it shortens door-to-device times, which translates to better patient outcomes.
So what does bypass actually mean? Do they literally skip the ER?
The definition can vary a bit between hospitals, but the core principle is minimizing or eliminating any unnecessary delay in the emergency department. Ideally, yes, the patient goes straight from the ambulance stretcher onto the cath lab table.
Wow.
Now, sometimes protocols might require a very brief stop, maybe for a central registration, putting on an ID band, getting a second IV line started if needed.
But quick stuff.
Right. The absolute rule, though, is no repeating the ECG if EMS already transmitted a diagnostic one. No lengthy physical exams that EMS already performed. The moment EMS confirms STEMI in the field, the destination is locked. CCL.
That speed is crucial, I get it. But does bypassing the ED potentially increase the risk of, say, a misdiagnosis getting through, especially if EMS teams have varying experience levels? Where's the safety net?
That's a really important point and a valid concern. Speed can't override safety. The consensus is clear. A focused history and physical exam must happen before the PCI procedure begins.
Okay, so there is a check.
Yes, but it's highly focused. You're quickly noting critical things. Does the patient have severe kidney disease? That affects contrast choices. Do they have known severe aortic stenosis? That makes low blood pressure extremely dangerous.
Or things like DNRs.
Exactly. Advanced directives, futility criteria, things that might completely change the goal of care. This focused assessment takes just moments, but the information gathered is absolutely vital.
Let's talk about the flip side of this rapid activation system, the false STEMI activations. We know ECGs aren't perfect. There are mimics out there. How does the consensus suggest handling the system's strain from false alarms?
Yeah, false activations are, well, they're tough on the system. Things like pericarditis, Brugada syndrome, sometimes electrolyte problems like severe hyperkalemia, even stress cardiomyopathy. They can all look like a STEMI on the ECG initially.
And that triggers the whole 20-minute response.
It triggers the whole cascade. And if you have a high read of these false alarms, it leads directly to staff fatigue, frustration, burnout, frankly. When the team is constantly rushing in for non-emergencies, their readiness for a true STEMI can, degrade over time.
So what's the fix? Slow down the activation?
No, the consensus definitely doesn't recommend slowing things down. The answer lies in improving the upstream diagnosis. Better education, continuous training focused specifically on differentiating STEMI from its mimics.
For the ED docs and EMS?
Exactly. Sharpening the skills for interpreting those subtle or atypical ECGs is key. It's about reducing the false positives while keeping the rapid response for the true positives intact.
Okay. And what if the ECG isn't a classic STEMI pattern, maybe like a circumflex occlusion, which can be sneaky, but the patient's symptoms are really convincing? What tools does the team use then to make the call quickly?
Great question. We have specific maneuvers for those high suspicion cases. The consensus highlights getting additional ECG leads V7, V8, V9. These look at the back wall of the heart, the posterior wall.
Which standard leads might miss?
Precisely. Posterior infarcts are a common cause of these occult STEMIs. And then, crucially, there's the increasing use of bedside point-of-care ultrasound, POCUS.
Ultrasound right there.
Yes, in the ED, or even rolled right into the CCL. With POCUS, the operator can quickly look for acute regional wall motion abnormalities, basically. See if a section of the heart muscle isn't contracting properly.
Ah, direct visualization.
Right. If you see that, it strongly points towards an acute coronary blockage, even if the ECG isn't textbook perfect. POCUS lets the team move forward confidently without wasting precious time.
Okay, let's shift focus. We've got the patient to the lab quickly. Now we're talking about the technical start, getting arterial access. The consensus puts a lot of weight here. What's the top recommendation?
The Class I recommendation, the strongest level, is unequivocally for transradial access, using the artery in the wrist rather than the femoral artery in the groin.
And why is that so strongly preferred?
It's a cornerstone of what we call bleeding avoidance strategies. And these strategies have been proven to save lives in STEMI. Radial access dramatically cuts down the risk of bleeding at the access site, hematomas, pseudoaneurysms, nasty vascular complications compared to the femoral approach.
Just mechanically easier to control.
Think about it. With the radial artery, you can usually stop the bleeding effectively, just by applying direct pressure or using a simple compression band. The femoral artery is much larger, deeper. Stopping bleeding there often requires prolonged manual pressure, sometimes specialized closure devices.
And if it does bleed?
Bleeding complications in the groin are far more likely to be serious. They might require blood transfusions, extra procedures, and in rare cases can even threaten the limb. The data clearly shows that avoiding these issues with radial access translates into lower overall mortality, particularly for high-risk patients.
So radial is the default. But it's not always possible, right? The consensus must have guidance for when femoral is the necessary choice.
Absolutely. Femoral access is still essential in specific situations. The document lays out roughly 3 main scenarios. First, just technical or anatomical reasons.
Like the artery's too small.
Exactly. If the radial artery is tiny, very twisty, or maybe it's already blocked from a prior procedure, you simply might not be able to get the catheters through it.
Okay, what else?
Second, and this is critical, patients presenting in advanced cardiogenic shock, or CS. These are the sickest patients, hearts failing as a pump. They often need large bore access.
For support devices.
Right, to place mechanical circulatory support devices, things like Impella pumps or sometimes specialized balloon pumps. These need much larger sheaths, which means you need the bigger, more reliable femoral artery.
And the third scenario?
Patients who have had prior coronary artery bypass graft surgery, CABG. While you can sometimes still use radial, it gets complicated. The grafts themselves might have originated from the internal mammary artery or even the radial artery.
Ooh, interfering with the plumbing.
Kind of. Plus, finding and engaging those bypass grafts, especially the saphenous vein grafts coming off the aorta, can be technically trickier navigating from the left wrist. Sometimes femoral, or maybe even the right radial artery, offers a better angle.
Makes sense. Now, regardless of whether you go radial or femoral, safety during the actual puncture is key. The consensus mentions best practices. What role does technology play here?
A huge role. Modern practice, and this is backed up by randomized trials, strongly favors using ultrasound guidance for getting access.
Not just feeling for the pulse.
Not anymore, ideally. Ultrasound isn't just a nice-to-have. It demonstrably reduces the number of attempts needed, cuts down the time to get access, and therefore lowers complication rates.
How does it work for each site?
For radial, you use ultrasound to find the artery, ideally puncturing about 1 to 2 centimeters proximal to the bony part of the wrist, the styloid process, to avoid hitting nerves. For femoral, we still use fluoroscopy, the X-ray, to identify the femoral head as a landmark.
The bone target.
Right, targeting the lower half of the femoral head is safest. But then we routinely use ultrasound on top of that to visualize the artery directly, making sure we puncture the front wall cleanly. Avoids going through the back wall or hitting the vein.
Precision matters. Okay, access is secured. Now the diagnostic part. The consensus says do a complete angiogram look at both left and right coronary systems, any bypass grafts during the initial procedure. But then there's that timing question again. Do you do the full look before or after fixing the main problem?
Ah, yes. The timing dilemma. This is a constant point of discussion in the cath lab. The consensus acknowledges there's a trade-off.
Speed versus information.
Essentially, if the infarct artery seems really obvious from the ECG, like a classic anterior STEMI pointing straight to the LAD artery, then going directly to PCI on that culprit vessel saves time, gets blood flow restored faster, and in unstable patients, speed is absolutely critical.
But the what if?
Exactly. Doing the complete angiogram before you intervene on the culprit has major advantages. First, it confirms you've actually identified the right culprit lesion, especially if the ECG was a bit ambiguous.
Okay.
But maybe more importantly, it immediately shows you if there's other severe non-culprit disease lurking. Imagine finding a 90% blockage in the left main artery while you're treating a STEMI caused by the right coronary artery.
That changes everything.
Completely. Knowing about that critical left main disease up front influences your guide catheter choice, tells you if you need hemodynamic support like a pump ready to go, and might even shift the entire strategy toward needing urgent bypass surgery or doing a protected PCI.
Information is power there. Let's talk about another piece of information gathered during the procedure, one that might seem subtle but has huge implications later. Measuring the left ventricular end diastolic pressure, or LVEDP. Why is this number so important?
LVEDP is arguably one of the most powerful prognostic markers we can get easily during the procedure. It's the pressure inside the left ventricle, the main pumping chamber, right at the end of filling, just before it squeezes.
What does a high number mean?
A high LVEDP tells you the ventricle is stiff, non-compliant, or maybe just overloaded with fluid. And that high pressure is strongly linked to worse outcomes, higher short-term and long-term mortality, and a much greater risk of developing heart failure down the road.
So getting that number during the STEMI procedure itself is key.
It's incredibly valuable. It gives you objective, real-time data. If you see a high LVEDP, it directly informs how you manage the patient after the PCI is done. It tells you this patient needs careful volume management, maybe diuretics started early, maybe drugs to reduce the afterload, the resistance the heart pumps against.
It guides the next steps immediately.
Yes, it shifts the focus from just opening the artery to actively managing the systemic consequences of the heart attack right from the start.
Given how important LVEDP is, what about the old school left ventricular angiogram, injecting dye directly into the ventricle? Does that still have a role in routine STEMI care?
Its role has really diminished quite a bit. With POCUS being so readily available now, we can assess the heart's function both globally and regionally, non-invasively and quickly.
So when would you do an LV-gram?
It's generally reserved for specific, often ambiguous situations. Maybe you're trying to diagnose MINOSA, that's myocardial infarction, with non-obstructive coronary arteries, and you need to rule out something like stress cardiomyopathy, Takotsubo.
Okay.
Or if you suspect a mechanical complication in a patient who's in shock, like a hole between the ventricles, a VSD, or maybe a ruptured papillary muscle causing severe mitral valve leakage, then the electrocardiograph can confirm it. But we generally avoid it, especially in patients who present late, because there's a small risk of dislodging a blood clot that might have formed inside the ventricle.
Got it. Okay, let's move into the thick of the intervention itself. Diagnostics done, wire is across the blockage. Now you have to deal with the clot, the thrombus, and the risk of poor perfusion. What's the consensus on the very first step to try and establish some flow?
Right, so the wire is across. If the vessel's still totally blocked, TMI zero flow. The first move is often what we call balloon dottering.
Dottering.
Yeah, it sounds a bit funny. It means passing a very small, deflated, and very soft, compliant balloon across the blockage. The goal isn't really to fully open the artery yet.
Just to nudge things.
Exactly.
Yeah.
Gently push the clot aside just enough to get a trickle of blood flow going, maybe TMI 1 or 2 flow. This does two things. Confirms your wire is definitely in the true vessel distally, and crucially, it lets you actually see the vessel beyond the blockage before you commit to putting a stent in.
Why a small, soft balloon?
We use an undersized balloon and very low inflation pressure specifically to minimize the risk of distal embolization, breaking off chunks of clot and sending them downstream where they can block the microcirculation.
Makes sense. So after dottering, what's next? Stent right away.
It depends. From there, the operator makes a choice. One option is direct stenting. If the lesion looks relatively soft, not much calcium, just thrombus, then going straight to placing the stent can be a reasonable strategy. It's often associated with better final flow, less contrast dye used, maybe better outcomes.
But if it's not straightforward,
Then you need lesion modification before the stent. If there's heavy calcium or a really tough fibrous plaque underneath the clot, you have to prepare the vessel. That means using tools like atherectomy rotational or orbital, or maybe lithotripsy, the shockwave balloon, to crack the calcium so the stent can fully expand later.
that brings us squarely to the thrombus itself. A big clot is a huge risk for causing problems downstream MVO, no reflow. How do you even grade how much clot there is?
We use the TMI thrombus scale. It's a visual grading system based on the angiogram, ranging from grade 0, no visible clot, up to grade 5, which is a massive, often totally occlusive clot that fills the vessel lumen.
And grades 4 and 5 are the big worry.
Those are the ones associated with the highest risk of distal embolization and no reflow. And this leads directly into one of the biggest controversies in STEMI intervention over the last decade or so: manual aspiration thrombectomy. Trying to suck the clot out.
Right. That used to be pretty common practice, didn't it? But
Yeah.
the big trials really changed things.
They absolutely did.
Mm.
We have to look at the evidence here. The major randomized controlled trials, specifically TASTE, which had over 7,000 patients and total trial, TASTE and total. The total trial had over 10,000 patients. These trials investigated using routine manual aspiration thrombectomy for all STEMI patients.
And the results.
They were remarkably consistent and frankly disappointing for aspiration proponents. Neither trial showed any benefit in reducing the primary endpoints, things like all-cause death, repeat heart attack, stroke, or heart failure.
No clinical benefit at all.
None overall. And worse, a subsequent meta-analysis combining data from multiple trials actually raised a significant safety flag.
What was that?
Routine aspiration, especially when used aggressively in patients with high thrombus burden, was associated with a small but statistically significant increase in the rate of stroke.
Stroke. How?
The theory is that the suction and manipulation involved might actually fragment the clot, dislodging tiny pieces that travel up into the brain circulation. So given the lack of benefit and the potential harm, the current consensus and guidelines are very clear. Routine aspiration thrombectomy is discouraged. Class 3 recommendation, meaning it should be done routinely.
So is aspiration completely off the table then? Or are there specific times it's still considered?
It's not completely gone. It remains an acceptable bailout strategy.
Bailout,
Meaning it's reserved for very specific, highly selected cases. Typically, patients with a massive thrombus burden, TMI grade 4 or 5, where your initial attempts to restore flow like balloon dottering or very gentle balloon inflation have failed. The vessel is still blocked by clot.
So when nothing else works.
Right. In those situations, the perceived risk of definite no reflow from that huge, persistent clot might be judged by the operator to outweigh the potential risks of attempting careful, selective aspiration. It's the last resort, not a first move.
Okay, so for those really tough cases where the clot just won't budge or there's a lot left even after ballooning, what other specialized tools or strategies does the consensus mention?
There are several options for refractory thrombus. First, adjunctive drugs. We can use glycoprotein IB inhibitors or GPIs. These are potent antiplatelet agents.
Delivered how? 5e or...
Both. You can give them intravenously, systemically, or you can inject them directly into the coronary artery via the catheter, that's intracoronary or IC delivery. The trial data comparing IV versus IC is a bit mixed on long-term clinical outcomes.
But any advantage to IC?
Some meta-analyses suggest that IC delivery might lead to better markers of reperfusion itself, like faster ST segment resolution on the ECG, probably because you get a much higher drug concentration right where you need it at the site of the clot.
Okay. What else besides GPIs?
For really dense, stubborn thrombus, especially the kind you sometimes see in old, degenerated saphenous vein grafts, or SVGs, or even in some complex cases like STEMI complicated by COVID-19, there's the excimer laser.
Laser?
Really? Yes. It's a specialized catheter that uses laser energy to essentially vaporize the thrombus. It's effective, but complex, expensive, and definitely reserved for very challenging refractory situations.
And then there's this idea of waiting, deferred stenting.
Right. Deferred stenting is another strategy, primarily for patients with a massive residual thrombus burden after you've managed to restore some initial flow with balloon angioplasty.
So you open it, but don't stent it right away.
Exactly. You achieve flow, then you wait. Maybe for a few days, typically 3 to 5 days, while keeping the patient on strong antiplatelet and anticoagulant medications.
What's the rationale?
The theory is that this waiting period allows the body's natural processes, aided by the drugs, to break down and shrink that massive clot burden. Then, when you bring the patient back for the stent, there's less clot to get squished out distally, potentially reducing the risk of no reflow during stent deployment.
Does it work?
The clinical trial results have been pretty mixed, honestly. Some smaller studies showed promise, but larger trials haven't consistently shown a clear benefit over immediate stenting. So the consensus views it as an available option, but one that requires really careful patient selection and experienced judgment. It's not a routine strategy.
Okay, let's pivot directly to that dreaded complication. No reflow. You open the main artery, looks great on the angiogram, but the heart muscle downstream isn't getting blood. That sounds like a disaster.
It is a major predictor of poor outcomes. No reflow essentially means failure at the tissue level the microvasculature is obstructed. We call this microvascular obstruction, or MVO.
And that leads to bigger heart attacks.
Yes. It's strongly linked to larger infarct size, impaired healing, and a significantly higher risk of death and heart failure long-term. The pathophysiology is complex. It involves tiny clots embolizing distally, spasm in the small arterioles, swelling of the endothelial cells lining those vessels, and inflammation, all choking off flow at the capillary level.
Since it's so bad, prevention must be key. What does the consensus say about preventing no reflow in the first place?
Prevention absolutely starts way before the patient even gets to the cath lab. Systemically, anything that reduces the total ischemic time, getting patients to present earlier, faster transport, quicker door-to-device times, helps preserve the microvasculature.
Any specific patient factors?
Yes. The literature suggests that good acute glycemic control, managing blood sugar, is important. Also, pre-procedural high-dose statins seem to help by reducing inflammation and improving endothelial function before the intervention even starts.
And technically during the procedure?
Meticulous technique is paramount. Careful wiring, avoiding aggressive balloon inflations, especially in heavily thrombotic lesions, and using those thrombus management strategies we discussed appropriately. Minimizing trauma to the vessel and clot is key.
But if no reflow does happen despite best efforts, what's the treatment strategy then? How do you try to fix it?
Once it occurs, the goal shifts to actively reversing the microvascular dysfunction. It's about tackling the spasm and trying to break up the microthrombi. The mainstay of treatment is pharmacological, giving vasodilators directly into the coronary artery.
What kind of drugs?
The consensus lists several options, often used in combination or sequence. Adenosine is common, as is nitroprusside. Calcium channel blockers like verapamil or diltiazem are also used.
Any reason to choose one over another?
Yes, and the consensus stresses caution based on the patient's overall condition. For example, you'd avoid nitroprusside in someone with severe aortic stenosis because it can cause a dangerous drop in blood pressure.
Right.
Similarly, verapamil and diltiazem have negative inotropic effects. They weaken heart muscle contraction slightly, so you'd absolutely avoid them in a patient who's already in cardiogenic shock. Diluted intracoronary epinephrine is sometimes used as a potent vasodilator in refractory cases, but again, with caution.
You mentioned earlier an unappreciated factor in treating no reflow, something beyond just the local drugs.
Yes, it's about the hemodynamics. It's the critical importance of maximizing coronary perfusion pressure, or CPP.
Explain that.
The microcirculation needs a pressure gradient to drive blood flow through those constricted, swollen, tiny vessels. CPP is basically the difference between the pressure in the aorta and the pressure inside the ventricle, or the right atrium, depending on which ventricle.
So you need good blood pressure.
You need adequate systemic blood pressure, yes. Sometimes we have to actively augment the mean arterial pressure, maybe using pressor medications. But just as importantly, you need to reduce the resistance downstream. And a major component of that resistance is high left ventricular end diastolic pressure, that LVEDP we talked about.
Ah, it comes back to LVEDP.
Absolutely. If the LVEDP is high, it's like the heart is squeezing the coronary microvessels from the inside, making it harder for blood to get in. So lowering LVEDP, often with diuretics or sometimes even with MCS devices, is crucial for improving microvascular flow. It's a two-pronged approach. Boost the pressure driving blood in and reduce the pressure resisting it.
That makes a lot of sense. Okay, let's talk about some of the more advanced tools becoming common in the cath lab. Intracoronary imaging, IVUS, and OCT. How does the consensus position these in STEMI?
Intracoronary imaging represents a shift towards, real precision medicine within the cath lab. It's strongly recommended as a reasonable option, Class A, to guide PCI during STEMI.
Moving beyond just the shadows on the angiogram.
Exactly. Angiography gives you a 2D silhouette. IVUS, intravascular ultrasound, and OCT, optical coherence tomography, take you inside the artery. They let you see the plaque characteristics, measure the vessel size accurately, assess the extent of the disease. It's invaluable information.
Does using it actually improve outcomes, given it adds a bit of time to the procedure?
The data is increasingly supportive. While historically, imaging was maybe reserved for complex non-STEMI cases, a growing body of evidence, including observational studies and large meta-analyses, suggests that imaging-guided PCI leads to better outcomes.
Better how?
Reductions in MACE, major adverse cardiac events, lower rates of stent thrombosis, that dreaded complication where the stent clots off, fewer repeat procedures needed, and potentially even lower mortality compared to just relying on angiography alone.
Even in STEMI.
The data specifically in the STEMI population is still evolving. Large randomized trials focused purely on STEMI, like the ongoing ATLS OCT trial, are needed. But the underlying mechanisms make sense. Imaging helps you avoid the two big pitfalls of stenting, which geographic miss, basically. Not covering the entire disease segment with the stent. And critically, underexpansion or malapposition of the stent, when the stent isn't fully opened or isn't pressed firmly against the vessel wall. These are the leading mechanical reasons why stents fail later on. Imaging lets you see that and fix it immediately.
So are there specific situations where imaging isn't just reasonable, but pretty much essential?
Yes. It becomes crucial in a couple of key scenarios. First, obviously, for guiding optimal stent deployment. You use it to choose the right stent size based on accurate measurements of the healthy vessel segments nearby. And then after deploying the stent, you use imaging to confirm it's fully expanded, nicely opposed to the wall, and check the stent edges for any dissections caused by the procedure.
Troubleshooting, basically.
Precisely. And second, for investigating failure. If a stent thromboses acutely or later on, imaging, particularly OCT with its incredibly high resolution, is the best tool to figure out why. Was it underexpanded? Were the struts not covered by tissue? Did the stent fracture? Imaging helps diagnose the mechanism. It's also invaluable in those ambiguous Mannlicher cases to understand the underlying pathology. Was it plaque rupture, erosion, or something else entirely?
Okay, let's shift to the real cutting edge. Strategies aim specifically at reducing the amount of heart muscle that dies, limiting infarct size. We know infarct size is directly tied to long-term prognosis, so this is huge.
Absolutely. The ultimate goal beyond just opening the artery, achieving 2-3 flow, is to salvage as much heart muscle as possible. We talked about microvascular obstruction, MVO being a bad sign. Well, MVO is actually a pretty good surrogate marker for final infarct size. So therapies targeting MVO or reperfusion injury aim to shrink that final damage.
And there's actually an FDA-approved therapy in this space now, supersaturated oxygen, or SSO2. How does that work?
SSO2 is a really interesting technology. It's a catheter-based system used after the blocked artery has been successfully opened with PCI. It delivers highly concentrated, dissolves oxygen, much higher levels than you can get just by breathing oxygen directly into the just reperfused coronary artery.
What's the idea behind flooding it with oxygen?
The goal is to hyperoxygenate the stunned but still potentially viable heart muscle in the area at risk. By boosting the oxygen supply dramatically during that critical early reperfusion period, it helps the tissue recover and reduces the extent of cell death.
And did the studies show it works? You mentioned IC-HATE too?
Yes, the IC-HATE study provided key evidence. It focused on patients with anterior STEMIs. Those usually involve a large territory of the heart muscle who were treated within 6 hours of symptom onset and weren't in cardiogenic shock.
What were the results?
In that specific group, SSO2 therapy showed a significant average reduction in infarct size, but 28% smaller compared to controls, as measured by cardiac MRI later on.
That sounds pretty good. Why isn't it used universally then?
Well, the approval in the studies focused on that specific subset anterior STEMI, treated early, without shock. That limits its broad applicability right now. Plus, it requires a dedicated console and an additional infusion period after the PCI is finished, adding some time and complexity to the procedure. So it's an important tool, but for a selected population.
Got it. What about other approaches being investigated to limit infarct size or reperfusion injury?
There are a couple of major areas being actively researched. One is mild hypothermia, cooling the patient.
Cooling them down. Why?
The idea is that lowering the body temperature slightly, maybe to around 33, 35 degrees Celsius, dampens the body's inflammatory response and reduces the metabolic rate of the heart cells. This might lessen the reperfusion injury, the paradoxical damage that occurs when blood flow rushes back into ischemic tissue.
Has it worked in trials?
The results from large trials using systemic cooling methods like surface pads or intravenous cold saline have been pretty mixed, honestly. Some smaller studies showed promise, but bigger ones like CHILL-MI didn't meet their primary endpoints consistently.
So, is cooling dead in the water?
Not necessarily. Research is now shifting towards more targeted methods, like maybe infusing cold saline directly into the coronary artery during PCI, or using specialized cooling catheters. The thought is that faster, more localized cooling might be more effective, particularly for anterior infarcts where the benefit might be greatest. It's still investigational, though.
Okay. What's the other major area?
The other really exciting and perhaps counterintuitive area is left ventricular, LV, unloading.
Unloading. What does that mean?
It means using a temporary mechanical circulatory support device, most commonly a microaxial flow pump like Impella, to actively suck blood out of the left ventricle and pump it into the aorta, thereby reducing the workload of the heart.
But you do this before opening the artery.
That's the key innovation being tested. The strategy is to insert the pump and start unloading the ventricle before you actually perform reperfusion with the balloon and stent.
Why would that help? It seems like opening the artery first is the priority.
It is the priority, but think about what the heart is doing before reperfusion. When the artery is blocked, the LV is desperately trying to pump against high pressure, stretching its walls, consuming oxygen it can't get. This high wall stress itself contributes to cell death and stunning.
So unloading reduces that stress before the reperfusion hit.
Exactly. By putting the ventricle at rest, reducing its oxygen demand, and lowering that wall tension before you restore flow and trigger the inflammatory cascade of reperfusion, the hope is you can preserve more myocardium. The initial feasibility was shown in the pilot door to unload STEMI trial.
And is there a bigger trial looking at actual outcomes?
Yes, the large randomized STEMI DTU door to unload trial is currently ongoing. Its primary endpoint is infarct size measured by MRI. It will hopefully give us a definitive answer on whether this unload first strategy really makes a difference in salvaging heart muscle. It's a very hot topic right now.
Fascinating. Okay, let's move into Section 5, adapting strategies for special circumstances or challenging anatomy. Starting with the really sick patients. Cardiogenic shock, CS. Mortality here is still frighteningly high.
It is. CS is that vicious cycle where the heart fails as a pump, leading to poor tissue perfusion, which further damages the heart. The consensus document rightly emphasizes that prompt revascularization, opening the blocked artery, is the cornerstone of improving survival. That principle was established way back by the SHOCK trial.
But just opening the artery isn't always enough in shock.
No, management has become much more sophisticated. A key advance is using algorithmic risk stratification, specifically the SCAI stages of cardiogenic shock. These range from stage A, at risk, to stage E, extremis, or near death.
How does staging help?
Using these stages consistently helps standardize care, guides the timing and intensity of interventions, and has actually been shown to be associated with improved survival rates. It helps teams recognize how sick the patient is and escalate therapy appropriately.
Once a shock patient hits the cath lab, what are the absolute must-do diagnostic steps? You can't just rely on how they look, right?
Absolutely not. Clinical assessment is notoriously unreliable in shock. Two things are considered essential in the CCL according to the consensus. First, routine use of POCUS, that bedside ultrasound.
Why POCUS again here?
You need to rapidly assess how both ventricles are functioning, but critically, you need to rule out a mechanical cause for the shock. Is there a hole in the septum? VSD. Has a papillary muscle ruptured, causing torrential mitral regurgitation? These are surgical emergencies, and POCUS can spot them quickly.
Okay, POCUS first. What's second?
Second is performing right heart catheterization, RHC, using a Swan-Ganz catheter.
Getting the pressures inside the heart.
Exactly. RHC provides comprehensive hemodynamic data,
Yeah.
cardiac output and index, filling pressures like the pulmonary capillary wedge pressure, systemic vascular resistance, and critically, the cardiac power output or index, which reflects the actual pumping capability of the heart.
Why is that data so vital?
Because it provides objective numbers to guide therapy. It tells you why the patient is in shock. Is it pump failure, vasodilation, volume overload? This information is far superior to just guessing based on blood pressure, and it allows for tailored use of fluids, pressors, inotropes, and helps decide if and when to use mechanical circulatory support, MCS. RHC guidance is clearly associated with better outcomes in shock.
Speaking of MCS, we have these powerful pumps like Impella now. There was a big trial recently, the Danish-German cardiogenic shock trial, that shed some light on their use. What did it find?
Yes, that trial compared early routine use of an Impella CP pump versus standard medical therapy in patients with severe cardiogenic shock, mostly SCAI stage C or D, complicating acute MI.
And the outcome, did the pumps help?
They did show a significant reduction in the primary endpoint of 30-day all-cause mortality in the group randomized to the Impella pump strategy.
Sure.
So it supported the concept that aggressive hemodynamic support can improve survival in these very sick patients.
But there was a catch, wasn't there?
There was a significant catch. The trial also found a substantially higher rate of major adverse events in the MCS group.
What kind of events?
Complications related to the device and access, primarily. Things like severe bleeding, limb ischemia requiring intervention, hemolysis, red blood cell breakdown, and even sepsis.
So, trade-off. Better survival, but more complications.
Precisely. The data highlights that while these advanced MCS devices can be life-saving by supporting circulation and allowing the heart to rest, they are not benign. They introduce significant procedural risks that demand meticulous attention to vascular access technique, careful patient selection, and diligent post-procedure management.
A complex decision. Okay, let's switch gears to non-atherosclerotic causes of STEMI, the Minoka category, myocardial infarction with non-obstructive coronary arteries. How often does this happen, and why is recognizing it important?
Minoka makes up roughly 8%, maybe a bit more, of all MIs. Recognizing these alternative causes is critical because the treatment is often completely different, sometimes even opposite, to standard plaque rupture STEMI management.
Give us an example.
The classic example is SCAD spontaneous coronary artery dissection. This is a tear in the artery wall, often seen in younger women, frequently without traditional cardiac risk factors.
And how do you manage SCAD differently?
The key principle in SEC is caution, especially with instrumentation. Trying to wire the dissected vessel, balloon it, or stent it carries a very high risk of extending the dissection, causing the false lumen, the tear channel, to collapse the true lumen, or causing the intramural hematoma, blood clot within the wall, to worsen. It can be catastrophic.
So the instinct to just open it up is wrong here.
Often, yes. If the patient is stable and there's still good flow down the true lumen of the vessel despite the dissection, the preferred approach is usually conservative medical management. Let the vessel heal on its own. PCI or bypass surgery is generally reserved only for patients with ongoing ischemia, complete vessel occlusion, high-risk anatomy, or hemodynamic instability. You're treating a tear, not a blockage from plaque.
Okay. What's another Minosia cause?
Epicardial coronary vasospasm. The artery itself clamps down severely. This can be triggered by certain substances. Cocaine is a classic trigger. Some migraine medications like triptans, or sometimes just severe emotional or physical stress.
How do you handle spasm in the lab?
The absolute key step during the angiogram, if you suspect spasm, is to administer intracoronary nitroglycerin. Give nitro directly into the artery.
Why is that essential?
Two reasons. First, it helps diagnose and treat the spasm, hopefully relieving the patient's symptoms and restoring flow. Second, and just as important, it ensures you get an accurate assessment of the vessel's true size after the spasm resolves. If you were to stent a vessel while it's still spasming, you'd almost certainly oversize the stent based on the narrowed appearance. Then, when the spasm relaxes later, the stent would be too big, potentially leading to problems.
Got it. Any other Minoka causes to mention?
Coronary embolism. This is where a clot travels from elsewhere, maybe the heart chambers due to atrial fibrillation, or even from the venous system through a hole in the heart and lodges in a coronary artery.
How do you spot that?
You suspect it when you see definite thrombus on the angiogram, but there are no signs of underlying plaque rupture or atherosclerosis at that site. The vessel walls look smooth underneath the clot.
And the management.
It depends on the size and location of the embolus. Small clots that have traveled far down distally are usually managed just with potent antiplatelet and anticoagulant medications. Larger clots blocking a more proximal major vessel might require attempts at extraction using aspiration catheters or specialized clot removal devices. Importantly, stenting is generally not the primary treatment for embolism unless imaging confirms there was underlying plaque rupture that caused the clot to form there. Otherwise, you're just trapping a traveling clot without addressing the source.
Okay, let's tackle specific anatomical challenges. Patients who've had bypass surgery, CABG, how does managing a blocked graft differ from a native artery?
It differs significantly, and it depends on which graft is blocked. Saphenous vein grafts, SVGs, the ones typically taken from the leg, are notorious for developing diffuse disease and accumulating large amounts of soft, friable thrombus when they occlude.
High risk for stuff breaking off.
Extremely high risk for distal embolization and no reflow. Because of this, when intervening on SVG occlusions, operators often need to use distal protection devices, little filters or baskets deployed beyond the lesion to try and catch debris that breaks loose during ballooning or stenting.
Do they always work?
They help, but they're not foolproof. They can sometimes be difficult to deliver or can even compromise flow themselves. Also, you have to be very cautious with aggressive ballooning or stenting in SVGs, as the graft wall is older, weaker tissue than a native artery and can rupture more easily.
What about the lima graft, the internal mammary artery?
The lima, usually connected to the LAD, is generally a much more robust, long-lasting graft. When problems arise with a lima, it's often related to spasm rather than bulky plaque or thrombus.
So a different approach needed.
Yes. Intervening on a lima requires very careful technique. You typically use hydrophilic wires, which are very slippery, to minimize trauma. And liberal, often repeated, use of intracoronary vasodilators like nitroglycerin or calcium channel blockers is crucial to prevent or treat spasm during the procedure. You want to be gentle to preserve this vital graft.
Makes sense. Two other common challenges: heavy calcification and lesions at bifurcations. How does the consensus address these?
Calcification is a huge issue. It's present in maybe up to a third of STEMI lesions, and it makes everything harder. Calcium prevents balloons from opening the lesion properly, and critically, prevents stents from expanding fully.
And an underexpanded stent is bad news.
It's a setup for failure, particularly stent thrombosis. So if significant calcification is present, operators must be prepared to use advanced plaque modification tools before stenting. This means having things like rotational atherectomy, rotablator, orbital atherectomy, diamondback, intravascular lithotripsy, shockwave, or even cutting balloons available in the lab. You have to break or modify that calcium to allow for optimal stent deployment.
And bifurcations, where the vessel splits.
Bifurcation lesions, where the blockage involves the main vessel right where a significant side branch comes off, are also pretty common, maybe 10–20% of STEMIs. In a stable planned procedure, we have complex two-stent techniques for bifurcations.
But not usually in STEMI.
Generally not as the first approach. The consensus favors a provisional one-stent strategy for most STEMI bifurcations.
Meaning
You focus on stenting the main vessel across the side branch origin. You only intervene on the side branch if it gets severely compromised, pinched or blocked by the main vessel stent, or if it was already significantly diseased. This provisional approach minimizes procedural complexity, reduces the amount of metal implanted, shortens procedure time, and importantly lowers the risk of dislodging thrombus into the side branch or causing other complications in the acute, unstable setting of a STEMI. Keep it simple initially, if possible.
that seems practical. Okay, let's wrap up with Section 6. Quality improvement and looking ahead. Maintaining excellence requires constant vigilance, right? CQI.
Absolutely non-negotiable, especially for centers doing a high volume of STEMI PCI. The consensus stresses the need for dedicated STEMI committees or programs within hospitals. These groups need to track every single STEMI case, not just the ones with bad outcomes.
What are they looking for?
They're looking for system performance. Identifying bottlenecks: is EMS transport taking too long? Is the hospital consistently meeting that 20-minute CCL activation goal? Are there delays in diagnosis in the ED? Then implementing targeted fixes to address those specific problems. It's a continuous cycle of measure, analyze, improve.
What specific metrics should hospitals be tracking according to the consensus? It's more than just the old door-to-balloon time, isn't it?
Oh yes, much more comprehensive now.
Yep.
Key metrics include door-to-ECG time. How quickly is the diagnostic ECG done? For patients arriving via EMS, it's first medical contact to device time, measuring the entire system from field contact to artery open. For walk-in patients, the traditional door-to-device time is still important.
What about complications?
Yes, tracking paraprocedural complications, bleeding, stroke, kidney injury, vascular issues, and critically, tracking the balance between true positive STEMI activations and false activations.
Why track the false alarms?
Because, as we discussed, a high false activation rate burns out staff and wastes resources. If that rate is creeping up, it signals a need for better upstream education or diagnostic protocols. Optimizing that true-false balance is key to maintaining system readiness and efficiency.
Okay, looking forward now. The final section discusses future directions. What emerging technologies or approaches might help plug some of the current gaps in STEMI care?
One major area is artificial intelligence and machine learning are showing huge promise. The goal is to develop sophisticated scoring systems that integrate multiple variables. Maybe subtle ECG findings the human eye misses, clinical factors like age and symptoms, perhaps even biomarker data to predict the likelihood of an acute coronary occlusion with much higher accuracy than the standard ECG criteria alone. This could get patients with atypical presentations to the cath lab much faster.
Very cool. What about measuring success after the PCI? You mentioned TMI flow earlier, but is there something better coming?
There's a potential paradigm shift here. Right now, success is largely defined by achieving good TMI flow, seeing the dye flow quickly down the main epicardial artery. But that doesn't guarantee perfusion at the tissue level. The future focus might shift towards quantitatively measuring the microcirculation using the Index of Microcirculatory Resistance, or IMR.
IMR. How does that work?
IMR is a measurement taken using a special pressure-temperature sensor wire placed down the coronary artery after the PCI. By injecting saline and measuring pressure and transit time changes, it calculates the actual resistance within the tiny vessels of the microcirculation, distal to the stent.
So it's a direct measure of tissue-level perfusion.
Exactly. TMI flow is subjective, looks at the big pipe. IMR is objective, quantitative, and reflects what's happening in the heart muscle itself. Studies have shown IMR correlates strongly with the presence of MVO, and importantly, with the final infarct size measured later on MRI.
So IMR could become the new benchmark.
Potentially, yes. Using IMR immediately post-PCI could become the gold standard for assessing reperfusion success. It could help us identify precisely which patients, despite having an open artery, are still having trouble at the microvascular level and might benefit most from those targeted infarct-sparing therapies like SSO2, aggressive vasodilators, or perhaps other future treatments focused on MVO.
Fascinating. Any other future directions mentioned?
One more practical area is improving coordination and communication, especially for patients being transferred between hospitals for PCI. App-based communication platforms are being developed and implemented.
How would apps help?
They allow for real-time transmission of patient data ECGs, vital signs, perhaps even low-res angiograms from the referring hospital directly to the receiving cath lab team. They can provide updates on estimated arrival times, facilitating smoother handoffs, and potentially shortening those critical transfer delays, further improving overall system time to treatment.
Makes sense. Technology streamlining communication.
Okay, this has been incredibly thorough. Let's try to synthesize. What's the main takeaway message for our listeners from this deep dive into the SCAI consensus?
For you, the learner, I think the core message is that top-tier STEMI management is really this complex dance. It demands a seamless, rapid system of care from start to finish. It requires incredible precision in the technical aspects, choosing the right access, using imaging wisely, and it needs constant vigilance and smart problem-solving when faced with challenges like big clots or the frustration of no reflow. It's multifaceted.
Absolutely. And maybe that leads us to a final provocative thought for you to chew on, something building on what we discussed. We talked a lot about the LVADP, that single pressure measurement taken during the procedure, and how strongly it predicts long-term outcomes like heart failure.
Right, a very powerful number.
So consider this. What if we move beyond just a single snapshot? How might the future development and use of continuous real-time hemodynamic monitoring, not just one LVEDP p-value, but tracking pressures and flows dynamically in the hours immediately after PCI, how might that fundamentally change our immediate post-STEMI management? Could we start proactively tailoring therapies in real time to optimize hemodynamics and potentially improve those long-term prognoses even further? We might shift from just opening the pipe to actively managing the resulting hemodynamic storm in a much more personalized way.
Wow. Moving from reactive to truly proactive, personalized post-PCI care based on continuous data. That's definitely food for thought. Thank you for watching The Funnel Effect.